is Professor Tunu and Professor Aldo Hayan inside. Okay, we have the signal from the PCO that we can start today's session.
You can begin.
Okay. Good morning. Good morning once again, and welcome to the third session for this morning's lecture of ELSA. For the first ever virtual conference of the endoscopic laparoscopic surgeons of Asia. We are now at the surgical education session. I'll be co-chairing this one with Professor Tunu from Myanmar and Professor Aldo Hayan from the Kingdom of Saudi Arabia. Professor Tunu. Is Professor Tunu inside? Prof?
I don't think so. He joined.
Okay. Can we go to Professor Aldo Hayan? Aldo, please.
Hello. Good morning, everybody. It is. I'm from Saudi Arabia, and welcome for the speaker. And I hope we're successful. And it is 6 o'clock in the morning, so it's good. So nice to meet all of you in Corona time.
I think you need to have some coffee first. Good morning, Professor Aldo Hayan. Anyway,
good morning.
We have 5 lectures reserved for you today with regards to surgical education. Introduce first the first speaker. Our first speaker, Dr. Ghaffur Mubarak, is a general surgeon and bariatric surgeon from Malaysia. He is the founding member of the Malaysian Hernia Society, where he holds the position of president currently. And he runs a practice at the Island Hospital of Penang, Malaysia, and has represented Malaysia in numerous times in conferences. He acted as the secretary for the recent ELSA Congress in Kuala Lumpur and acted as the treasurer for the Malaysian Society of Endoscopic Laparoscopic Surgeons of Malaysia. Ladies and gentlemen, I would like to introduce Dr. Ghaffur Mubarak, who will be talking about managing surgery training education, privacy, and medical legal aspects during COVID and the post-COVID era. Ghaffur?
Thanks. Thanks, Alan. Thank you so much. Thank you, Alan. Thank you, Professor Aldoyan, and thank you, Dr. O, for the kind introduction. Let me just share my screen, then I think I can proceed from there. Okay, so can everybody see it?
We can see your slide now, Ghaffur.
Okay, so as Alan mentioned, I am Dr. Ghaffur Mubarak and I'm from Malaysia. And I actually originate from a very small island in Malaysia called Langkawi. You can see some pictures there. We had the pleasure of hosting Professor Aldoyan and Alan in Langkawi about 2 years ago. And I hope that after all this is over, we can all meet up again and have a good time. So this topic will be on managing surgery, training, education, privacy, and medical legal aspects during COVID and post-COVID era. And my experience with managing the medical legal aspects, especially with surgery in Malaysia, comes in quite useful. And David thought it was a good idea if I was able to share some of our experiences, as well as how we have somehow or other evolved from pre-COVID era to a COVID era now, and what are the subtle differences associated with how we deal with things. So we used to basically meet up like this in meetings. We used to have close contact with each other. Conferences were organized in a way where we have a lot of personal touch. And this applies to also education and training, where we are able to gauge to a large extent the experience of our crowd, and we are able to tailor our training to the crowd. For example, if we were to organize a conference for nurses, then we are able to tailor the training for nurses. If we are organizing a workshop for consultants and specialists, then we are able to tailor that training for the expertise of those consultants. And also we foster a lot of personal relationships with each other, so that when we have interactions such as those, if there is an exchange of ideas or there is a need for us to travel or them to come to our place for training, we are able to foster that. Unfortunately, now we are in the era of webinars. I think all of us here have had an overdose of webinars during this COVID era. I think the most that I have had in one day is 4. And even that, I felt that it was very stressful. And I think speakers like Professor Aldoyan and Alan definitely have much, much more in a day as compared to I have. So we are in this era of webinars because we are unable to travel. And so we are able to disseminate information in a more efficient manner, I would say, because we are able to capture a larger crowd. We are able to prepare a more diverse panel of speakers for this at a lower cost. So it all works out to actually the delivery of information in a more efficient way. But being more efficient doesn't necessarily translate into the outcome of performing better surgeries or becoming safer for our patients. The reason is because our field of training requires a lot of personal interactions as well. And mentoring and apprenticeship requires the element where you have to actually dictate and help your trainees progress as they go along. So the traditional training requires mentoring and apprenticeship, workshops, clinical attachment, and international fellows were very, very popular before the COVID era. And now it has almost dwindled down to a very, very minimal amount. And live surgeries and short attachments. So what about post-COVID era? Post-COVID era, you can see that the main issue is webinars, webinars, and webinars. In fact, in a day, you can get more than 4, more than 5 webinars. You have now evolving VR platforms, virtual VR platforms that are coming up. You have got teaching videos that are trying to replace apprenticeship, in which trainers design teaching videos to reach out to candidates that don't have to physically travel, and they can review those teaching videos and then replicate the procedures. The problem with this is the teaching videos are not tailored for each individual, but it is a one model fits all. Therefore, it becomes difficult to actually decide which one is more suitable for each candidate. Simulator-based teaching now has become very popular, and more because technology has evolved and we have better endo simulators now. And this is akin to flight simulators that pilot train for. And they have, when they train for scenarios, we can actually replicate those scenarios in simulations for surgery. And of course, the online congresses like the one that we see today. It is getting more and more popular. But the challenges with online congresses include the fact that sponsors are a bit reluctant to participate in big amounts. So when this is a congress, a sponsored element is also very important. The other thing is, when you have an online congress, you have to tweak a lot of back-end work. For example, with regards to the technology, the bandwidth, the introduction of speakers, bringing in delegates on a virtual platform. So it's very challenging and technical in that aspect, as compared to just bringing everybody into a room and then discussing an idea or teaching them a new technique. So what are the benefits and problems with regards to the online platform now? The problem is the content is not regulated. Anybody who wants to actually talk about something can actually open a Zoom account, invite a few people, and they can talk about it. So this is different than what we have in our pre-COVID era. Basically, when we go for talks, we are recommended by somebody, or our papers have been published and people know about it. So the content that we're talking about is basically verified that we are someone who can actually talk about that particular topic. Difficult to adjust to audience. If you're in a public room, you can actually gauge what the audience is receiving, their level of expertise, their experience. But an online platform, you don't see your audience face to face. You cannot feel that, so you're unable to deliver more or less than is needed. Privacy is often neglected. I find that this is the most important element. When you go online, you tend to think that nobody else is watching except trained people and physicians. But actually, it opens up a lot of aspects with regards to privacy, especially when you're not taking things like encoding from end-to-end source seriously. You have got access to various techniques. That means people who come up with techniques without publication also can showcase their techniques in these online platforms. I will show it later in a while. And techniques are not verified. But there are some advantages. It is easier and cheaper to organize. It doesn't require room rentals, food, board, beverage, and things like that. Speakers are easy to obtain because it only depends on their time zoning. And then if they fit with the time zone, they can actually come into our platform easily. An audience does not need to interact. That means when we look in a room, we expect better interactions. But with an online platform, because of the chat function and things such as that, we find that the audience doesn't have so much of a role other than just to listen to us. So this is a recent conference a webinar that I had to present. And the topic was on safe cholecystectomy. So the first video was mine, and I had the benefit of being the host, so I could record. So the first was actually my video on showing safe cholecystectomy technique. So my video on this, my video on this, as you can see, when you're doing an online model, you want to have all the information provided, because you tend to be a bit more thorough as compared to face-to-face teaching. So you explain everything the best you can, and you show everything quite clearly. All right. So for example, at the end of this video, I will show most of the critical elements and also the views, and together with transposition of videos, so that the audience is able to appreciate the anatomy and also learn, and if possible replicate from that. Now, on the same platform that I was presenting, another speaker had a topic of other safe techniques. That means techniques that he does or he has seen. And this video was showcased. So just have a look at it quickly. It's just a short video. Right. Right. So as you can see, there is no focus on any safety element of the surgery. It is a technique that he has done, and then he feels that he's comfortable about. It may be a safe technique for that particular speaker, but it is not something that we can replicate to our junior trainees, and definitely not something that we want them to learn at the offset. So this is the problem with online learning. Our content verification is not as strict as it is on our regular platform. And this opens up an entirely new problem, in the sense that our audience is exposed to all these techniques that are not verified at times, and they tend to replicate it when they go back. So it's very careful that we realize this issue. Okay, let me just go on. Okay, so what about complications and management in terms of legal problems that are associated? The traditional model is patient sues, there is records for discovery, litigation, and then we get a decision. Now, post-COVID, I find that when I'm dealing with the Ministry of Health in Malaysia, I find that patients are very keen for video recordings. And this is because of the education that they have come up with the sense that they know that we are recording the video. COVID test pre and post, including exposure in the hospital, is very important. So depending on your protocol, it matters very much whether you test all patients or whether you test selective patients, because when it comes to a lawsuit, this will come into question. When do you actually do emergency procedures? Do you actually wait, or can you wait for the COVID results to come back? And when do you actually perform procedures with PPE and procedures without them? Okay. So this is another video with regards to a complication when performing lap cholecystectomy. Maybe I'll just play it for a while and everyone can have a look. As you can see, the dissection has already started very low below the sulcus ruveus. And subsequently, you can see that there will be some injury because initially one duct is cut here. Okay. And then he discovers there's actually another duct at the back. Okay, and then he tries to dissect the other duct at the back, thinking that it's the vessel. And then he finds another duct at the back again, and again puts a clip and tries to dissect that as well. And then after that, I get called because something is not right. So these are the types of problems that, you know, especially when you have all this video evidence now, it actually makes it a bit more difficult. So just to move forward quickly, because we are short of time, this procedure ended up with me coming in and performing a hepatico J. But I think the important aspect is you have to take a break and assess damage. This is one element that I think is lacking, especially when we see and review back the problematic tapes that we have with our with patients that litigate. Get help if available. Ask for advice, but also rationalize the problem on your own if you're alone, and always have an exit strategy in terms of drains and referring the patient out. So what happens when you have a litigation process now? Keep the video evidence, but don't give it out so easily unless it is compelled by a court order. Trigger the indemnity early. Always be represented when you're going for an inquiry, and always realize that COVID now is an important issue, and you have to stress the safety measures that you implemented on your patients in terms of detection of COVID. All right. So in privacy and patient confidentiality for COVID, it is now, what you call it, copying from YouTube is a very popular phenomenon, and claiming ownership. So you got to be very careful that this doesn't occur. And you have to know that if you share videos on public Zoom platforms, it becomes very easily accessible as public property. So you have to know that if you have faced problems later with regards to this video or the content, it becomes public property, and patients are able to use them in court, and makes it difficult for everyone. So this is another complication that that I had, which is when inserting a varus needle, and the middle sacral artery was injured, and then subsequently I was called to address the problem. So I'll just move forward quickly to so basically here the bleeding was from there. Just grab it with the Maryland and then burn it with a diatomy, and then inshallah everything will be okay. Okay, so and then when you remove the Maryland, if possible, use some water so that it doesn't stick onto the surface of the bleeder. Okay. Okay, let's move on. I think I'm short of time. So what about patients that request videos? If you have got a good rapport with patient and the outcome is good, for example, in the previous case, I'm able to solve the problem, it is okay to show the patient. But if the outcome is not good, it's preferably to hold it until a time is indicated when you have to show it. It's better to show snippets than to show the whole thing, and better to be transparent early if the outcome is controlled. Okay. So we have to discuss some issues regarding COVID testing for surgery and the medical legal aspects. Now, COVID testing is dependent on hospital to hospital, center to center. And it is important to be consistent in that one center when a protocol is identified. So if you are testing all patients for inpatient entry or for scopes or for daycare or for ward, it's better to screen all patients. If you're screening only symptomatic patients, screen symptomatic patients. But be always consistent with that decision, so that when it comes to a question in terms of legality, you can always fall back on hospital protocol and SOPs. So what do I think is the future training with surgeons, future in training for surgeons? I don't think COVID is going to go away anytime soon. So we have to work with COVID and around it. There's going to be more and more webinars. And I think conferences are going to be more in-house and webinar based. That means they're going to be a small group in-house, but the main bulk of the group is still going to be webinar based. There's going to be a lot of usage of VR and AI. What really saddens me is there's going to be this loss of apprenticeship. because I think that is one element that is very important in surgery. I learned a lot from Alan, who is on our panel here, by watching all his videos, going for all his talks and all that. And I feel it, and I feel very sad that, you know, this element of this personal apprenticeship, when someone comes and teach you and talks to you and encourages you, is somehow or other becomes dampened by COVID. And we are dependent on better tech to improve. So for example, the video that I showed in terms of cholecystectomy, you're depending a lot on the new harmonic instrument to actually perform the procedures, rather than focus on safe dissections and also keeping the procedure safe. I think I come to the end of my presentation. I hope I've not exceeded time too much. Thank you for allowing me this opportunity.
Thank you, Gafur, for a very nice lecture. I think Professor Tunu is already with us. Prof Tunu. You're still on mute, Prof.
Sorry, Alan, I lost the link. So
It's okay.
the preview room before.
Yeah, please introduce the next lecture.
Shall I do it?
Yes, Prof. And then Professor Aldohayan will.
Yeah. The next speaker is Dr. Samuel Chu from Singapore. So he's the co-founder of Calio. Within Calio, the healthcare segment is dedicated to the creation of novel medical education material through the use of mixed reality technology to solve persistent visualization and knowledge issues in surgical education. So may I call Dr. Samuel Chu to present his talk.
Thank you very much for the very kind introduction. Allow me to share my screen. Okay, so thank you everyone for joining our session this morning. Today I will be introducing Kialio's work with ELSA. So we are creating VR surgical education content for this new era of online learning. So to keep it brief, what are our goals when we are creating or when we are deciding how to create this content? Firstly, we are looking to provide a high quality experience. Firstly, from one aspect, it's about the resolution. It's also about what modalities we are using to create this content. And it's also about the production quality as well. So secondly, on a high level, we're also looking at the content in itself. And the content that we are trying to focus on, whether it's from the patient cases, or whether it's from the techniques used, or whether it's from instruments used, we are trying to focus on Asia context, that the content that we create is more relevant for the residents and learners in this area as well. So thirdly, we're also looking at broadly accessible and affordable content. There's a thing with technological development, is that it's very easy for costs to skyrocket, and eventually it comes to a point where trying to access all these education technologies has become a bit too expensive. So therefore, we've also set up it as a goal that this content for VR surgical education has to be accessible and affordable, especially here in Asia. So what can be achieved through real scene VR? When we look at VR, there's two ways we can present it. Right? One is either computer graphics based, or the other is real scene based VR. So for us, we have gone down with real scene VR for several reasons. There are certain aspects of filming surgeries live at the theater itself, at the table site, which allows for broadening of the learning objectives, which can be achieved in an intuitive manner. So whether it is your anatomical orientation, patient positioning, how you have set up your devices with your nurses, how you have arranged your team, and how the team coordinates with each other, whether it's your nurses, your surgeons, your anesthetists. These are all quite intuitive to observe and also learn about with a tableside view. And this is not to say that there is no use for computer graphics in virtual reality as well. So for us ourselves, we also use 3D models generated from CT or MRI scans. And these are used to help some of those who are newer to the procedure with some of the visualization of the anatomy or understanding techniques from an anatomical standpoint. So at this point, I am going to share a video.
Kialeo envisions learners having great VR views of the OT regardless of what device they own. Tableside views allow educators to describe techniques easily, including hand actions and team movements. It becomes easier for surgeons who are unfamiliar with the procedure to follow the lesson when the orientation of the patient and surgical team can be seen. There are multiple roles that learners must take on. Whether as a camera assistant or assistant surgeon, having the OT view allows learners to connect what they see through the laparoscope with the actions of the surgical team members in the theatre. Watching how other surgeons and assistants work helps to steepen the learning curve for those who are new to the OT. Having the OT view can also translate into training materials for the wider team, such as nurses and anesthetists. So using materials from the case, such as CT or MRI scans, can create 3D models that can help to explain the anatomy. Doing animations on the videos helps as well. Anatomically, it is easier to follow the video as the OT view helps with orientation and direction in which the surgeon is working toward. Overall, we find that this format is an efficient way of capturing what goes on during a surgery. The array of teaching objectives are also wider, including nursing education, interprofessional training, or multi-role training, anatomy, and so on. So let's look at another example in neurosurgery. Some teaching objectives are best done in the theatre itself. In this case, the surgeon is trying to let residents get a sense of the depth of the surgical site. The video you are seeing now is in 2D, but this was actually filmed in 3D, and the resulting stereopsis actually allows viewers to get a more accurate perception of the depth of field in the surgical site. The aim here was actually to be able to see the optic nerve, which is right at the bottom of the surgical site. In trying to make patient positioning more intuitive to understand, we used CT angiography slices to create a 3D model of the vessel structures, which are then overlaid onto the patient's head. Once again, viewing this in VR allows the vessels to be perceived as if they are really inside the patient's head, helping residents to understand why the patient was positioned as such. In summary, with online and digital learning becoming an inevitable part of the future, using virtual reality for surgical education helps to broaden the learning objectives that can be achieved in the digital space. In developing these new technologies, the key thing is still to continue doing this in an accessible and affordable way to benefit a larger number of learners.
Okay, thank you for following with that video. So in this era of disruption and COVID, we've heard this many times. This caused a lot of disruption to online learning and even face-to-face learning as well. So now we're going back to the basics with online learning and focusing on the learners. This has been one of the key drivers of why we came up with the 3 A's: affordability, accessibility, and applicability. When we're developing, these new technologies for learning, trying to balance the technological development with the practicality of it as well. So there are several key questions that our R&D seeks to address in the coming year, which is firstly, what kind of content or skill sets or knowledge sets can truly be impactful for learners in Asia when we're talking about online learning? There are several paths to take, right? The path can go deeper, so is to include more surgical skills or more surgical knowledge sets within these videos or within VR content. And another way is also to go broader, which is to include skill sets and knowledge sets for other members of the surgical team, such as nursing education, anesthetists, and so on. A second question that we also seek to figure out in this coming year is, what are the distribution methods which can balance the technological sophistication and the cost as well? So in developing new tools that learners can use, that educators can use to visualize certain concepts, we also have to keep very close watch on what's the cost as well, because we can have very good content, but if in the end the cost is prohibitive for learners to afford, especially here in Asia, then it makes a little bit less sense as well. And lastly would also be to look at what are the other adjacent disciplines or adjacent use cases which could also benefit from real scene VR. So there are other things out there such as patient education, pre-operative counseling. There are also clinical environment introductions to medical students. So there is also quite a broad array of other uses that VR can come and supply as well. So that brings me to the end of this presentation. Be happy to answer any questions later, or if you'd like to talk in greater depth, my email can be found on this slide as well. Thank you very much.
Thank you, Samuel. Very nice talk. Before we go to the next lecture, I would like to acknowledge the presence of a very good friend of mine, Professor Giovanni Dapri from Belgium. Good morning, Giovanni. I know it's very early in Belgium. Giovanni Dapri will be introduced later in this talk. May we go on now to the next lecture? Can we call on Professor Aldo Hayan to introduce our next lecturer? Prof?
Alan, can you continue introducing, because I haven't received the biodata of the speaker.
Yeah.
The next lecturer will be from will be about telementoring in the pandemic, which will be given by Professor Ong Mint U. Ong Mint U is a senior consultant surgeon at the Tan Tock Seng Hospital in Singapore. He's a clinical teacher at the Lee Kong Chan School of Medicine, Nanyang Technological University in Singapore. He's actively involved in the digital transformation project, especially of ELSA. He's the one responsible for our technology, also our website. Ladies and gentlemen, please welcome Dr. Ong Mint U from Singapore.
Thank you, Alan, for the kind introduction. It's my honor to be here. Yeah, so let me share my slides. Hope everybody can see my slides.
Yes.
Yes, thank you. So I'm talking about the telementoring during the pandemic. So we are in the ELSA. We have started the ELSA Digital Transformation Committee, and then I'm the part of the team member. So we have started on the ELSA digital transformation during the COVID-19. I have no conflict of interest. So currently I'm in charge of the telementoring, as the Professor Alan has mentioned. So with my team members from Philippines and Sri Lanka. So our aim is to start the telementoring project to try to run the 2 courses in the next 6 months, and then do some the governance of the telementoring as well. So let me share that we all know that the virus COVID-19 has disrupted, together with the technology, disrupted technology as well. So now look at the world map. You can see that how much the COVID-19 has affected to all over the world. And then, of course, is that followed by the safe distancing and then the travel restriction around the world. You can see that most of the countries are locked down or partial closure or full closures due to the COVID-19 situation. So you look at the history of the pandemics will come in the future as well. So it started from the Black Death in the 1334, and then now with the COVID-19. I think in the future, because of the war as a village, we can connectivity and then the travel, I think the pandemic is unavoidable. So hopefully we can use the non-disruptive kind of situations with the aid of the technology. So we all know that in the 2020, telemedicine or telehealth has been growth exponentially with the 64.3% growth is expected in 2020. That is the US data alone. So actually, tele project is not new. The first telesurgery was done this on 7 September 2001, which is 19 years ago in September. So we need to celebrate the 19 years of the first war telesurgery. It is across the New York to Strasbourg, and it was done by the Professor Mercier and Ding. It is using the ATM, the bandwidth, and then he, from the New York, operated the patient in the Strasbourg. They did a robotic cholecystectomy. So the robot they used was the Zeus, which is the pioneer of the current the intuitive robotic system. So this is Operation Lindenberg, which is done in 19 years ago. So what about the 5G and robotic? We talk about 5G with the connectivities. The robotic telesurgery is coming up. This is the one video showing the 5G and robotic telesurgery reported in the South China Morning Post. So the surgeons operated using the robots in about 30 miles away, and then this is using the 5G network system. So about 50 kilometers away, and then robotic telesurgery was performed. In the peak is an experimental. So the delay is only 100 milliseconds over the 5th generation network. So it is fast enough to avoid the potentially deadly mistake, which is the more important features we need to address during the tele or remote surgery or remote mentoring. So this is the one recently published in the Annals of Surgery on the 14th July 2020. Also the overall 5G telesurgery setup using the 5G on they are using the VidCom 3D exoscope castor system to the surgical site using the 5G network. So this is on our way. So actually, mentoring project has been started in 2008 by this IFAST group, and then they have started with the Tanzania, UK, and then the Tanzania, and then they managed to bring the laparoscopic surgery to the Tanzania by the remote or telementoring. So my interest in telementoring started 5 years back to improve the better patient care and then the surgical training in the hospital. And then along the way, I've been thinking how to bring in the telementoring to the surgical training in worldwide. So telementoring is actually a mentoring or training surgery remotely from a distance. The advantages of this will be to reduce the travel and time away from the work for both mentors and mentees, and then also to more time for the patient's care for both mentor and mentee surgeons. It has a potential improve patient's care with a high quality mentoring by the experts all over the world, because the time is shortened by the no need to travel, no need to go away from your home. You can still mentor from home or mentor from your office, like we are doing now from the virtual webinar. We are all over the world, and then we are meeting online. Same thing, the telementoring, the concept will be using the remote access of the technology, and then using the technology to bring in the gap, and then also to reduce the travel and the time constraints. The only thing is that the governance and framework for the patient safety and confidentiality, we need to work on it very to make sure that the patient safety and confidentiality is not compromised during the telementoring process. So ELSA outreach program was with the leadership of the Prof. Fomento and then the ELSA governors and other leadership. They're thinking about how to bring in the surgical, not to disrupt the surgical educations with the ELSA outreach program. So we all know that COVID-19 and the post-COVID-19 is to become a new normal. Even after the COVID-19 is over, some of the things will change. The technology, like we may probably adopt more on the virtual platform, online meetings rather than the physical meetings. Of course, we still love to meet up each other in the physically, but I think it may not be that commonly in the post-COVID era. Because of the travel restriction and disruptions, the telecommuting is the way to come. So like we are doing now, it's a lot of virtual conference and webinars. We found it very useful. We found it very helpful. And then in the future, telementoring will become a part of the process of our surgical education. So in terms of using the technology to overcome the limitation of the safe distancing measures, ELSA outreach program and the ELSA senior leadership has started the telementoring project, and I'm honored to be part of the team to lead the project. So actually, SAGES has SAGES Project 6 Technology Working Group, and then they just published in 2019 about the technology for surgical telementoring. So they even mentioned about the bandwidth necessary for the communication technologies. So some of the communication technology are not suitable for telementoring, especially the low bandwidth. And then we need a slightly higher bandwidth the communication technology in order to not to have a latency. The second is the frame rate or bandwidth compression ratios for the videos, because in the surgical mentoring, we need a lot of video, because the mentee will be sharing their videos and the mentor will be looking at the videos, and then the advice or mentor watching the video. So communication is very important. Connectivity is very important, as well as we shall not lose the high definition or standard definition of the video resolution as well. So recommendation is about 30 frames per second. I will share with you what are the limitations I encountered during the bringing up this project in the ELSA outreach program. So this is a summary of the surgical and the SAGES group, showing the recommendation for the telementoring and surgery. So the system and the solution should be compliant with FDA Class 2 device and HIPAA regulations. And then we need to have a good virtual VPN, patient safety, patient confidentiality, and then the encryptions, as well as the video transmission rate, and then the definition, the video resolution rate as well. And the most important thing is the teleillustration and the annotation are desired features and essential for the surgical training. Otherwise, we thought then there's a risk of the miscommunications over the language barriers. And the other thing is also we need to have a portable and an affordable solution for the telementoring. So there are some systems available for the telementoring. This is a STAR project led by the US group. They have started as the telementoring for the battlefield, for the US military. So you can see that it's a STAR project. They use a tablet to overlay of the augmented reality on top of the surgical field, and then we can draw on that to tell the mentee where is the supposed to cut, where is it supposed to be careful. So the other one is the Proximi. Proximi is a UK group. I think the founder is the plastic surgeon. So he started with the Proximi, which is to good platform for the telementoring. So this is a Proximi, which is a very good platform. You can see that the mentor can there's the augmented reality on top of the surgical video, and the mentor can use the finger to show where is the place for you to be take note of. So these are the solutions available for the telementoring. And then the other one is SAGES multi-institutional quality improvement initiative, and they started the sleeve gastronomy telementoring by Professor Nguyen and group in the United States. So you can see that there is a tele observation by the mentee first, and then after that they will be involved in the real-time telementoring after the mentor connects into the mentee's operating room using the laptop control stations. So it was the publish and share as a mentee welcome the initiative, and then it was a great learning tool with the great relationship, the proctor, etc. So this is something I found out is useful to set up. So you need a converter to the SDI cable to the special converter, and then it will connect to the laptop. So this is the videos I've done for the mockup. So you can see that this is I connect to the console, and then yeah. So this I'm constructing to using the laptop. And then this is the quality of the video. You can see the video is quite good. It's displaying on my laptop. It is directly connected using the converter cable to my laptop using the Zoom. And then this is the annotation. So there's the Zoom annotations. You can see that you can use annotations to annotate over the screen to communicate well with the mentee for the illustration purpose. Okay, this is the annotation software it's available in the Zoom. If you update to the latest Zoom update, you will get this annotation. So this is another one I use for the endoscopy as well. So you can see that there is the arrow. You can see this is the annotation, and this is a laser pointer for annotation, and this is a drawing over the share screen to annotation. And then our ELSA president, Professor Sutep, has started the ELSA first telementoring in the laparoscopic hernia repair cadaver workshop at the Chulalongkorn University under the Thai Hernia Society the project. So what are the challenges we will encounter for telementoring projects? Mainly will be the affordability, and then we need to be affordable for all the mentee. Mainly is the mentee institutions. And then the quality of the sound and video need to be addressed. And then the data transmission quality, as mentioned earlier, the latency of the video, and the annotation ability on the platform. The most important will be the patient safety and confidentiality, especially in the online platform when you do transmitting the video. And then what the cybersecurity is another main concern we need to address when we carry out the telementoring projects. So we need a very strong governance framework in order to embark on the telementoring project. So what are the plans for the ELSA outreach program, telementoring program? So we will standardize all the ELSA outreach program participating centers in terms of the hardware as well as the telecommunication requirements, standardize the protocol for the mentors, as well as the governance for the patient safety and confidentiality if we are embarking on the real life surgery connected to the war experts, together with the cybersecurity, and of course will be a data collection and survey for the research as well. So we are aiming to start small with some basic laparoscopy workshop on the telementoring during the COVID-19, and suturing workshop, animal cadaver workshop, and then finally we aim to embark on the live surgery telementoring in the near future. Thank you very much.
Thank you.
Yeah.
Thank you. Can we go on to the next lecture? Professor Tonu will introduce the next lecturer.
Yes. Next speaker is Jeffrey Domino from Philippines. Jeffrey Domino is an assistant professor and general surgeon whose field of specialty is minimally invasive surgery, endocrine surgery, and advanced laparoscopic and robotic surgery. He heads the division of minimally invasive surgery at St. Luke's Medical Center, Quezon City, Philippines. He completed his clinical fellowship training at the National University Hospital in Singapore. Had his international master's, held leaderships, Master of Management at McGill's University, Montreal, Quebec, Canada. He is the president of the Telemedicine Network of the Philippines and presently representing our country in the medical working group of the Telemedicine Development Center of Asia under the Asia Pacific Advanced Network. So, Dr. Jeffrey Domino, please.
Thank you very much, Professor. Can you hear me?
Yes.
Thank you
Yes,
very
Jeff.
much.
We,
Thank
we
you.
can more.
First of all, I'd like to thank Professor David Lomanto, Asim Shabir, and our president in ELSA, Professor Sutep, and my dear Kuya Allen Buenafe, who's the invitation really was a privilege and an honor. And it's also important to know that the choice of topics that has been presented has been quite important. And my talk is about the insights of online learning, which actually is a contributory, or it's a complementary to the previous talks of our distinguished speakers before. I have nothing to disclose. And just to give you an overview, I'll be talking about the matrix about telemedicine, the type and benefits of the online learning, and some insights by the online learners, which is quite important, which I will expound in a while, and to show you some online model of platforms for educational platforms in surgical education. But there's a lot, no? But we'll just focus on some that is what is relevant to our field. If you look at this matrix, the telemedicine matrix, which I got from the Telemedicine Network of the Philippines and the collaboration with the Telemedicine Development Center of Kyushu, Japan, with Professor Shimizu, it talks here that telemedicine is also talks about the doctor to the patient relationship, wherein that's where the teleconsultation comes in, as well as telemonitoring of the patient's condition, but also has a telemedicine, which is doctors to doctors, where the online learning or teleeducation comes in. And this is where most of our passions, or most of our speakers are doing actually. Just to give us a good clarification of terminologies, there's a lot of terminology you can see there online. We call it the online learning, the e-learning, and the digital learning. And to really encompass everything, e-learning, the digital learning includes a broader range of digital devices. So when we talk about simulators, virtual reality, augmented reality, that was just nicely presented a while ago, we talk about the digital learning. It actually has all the digital data of learners integrated into one system. So that's what we're doing now. It encompasses a lot of data. So to give you a perspective of the different online learning, it will help us also understand how we teach to our students or our residents or trainees. There are several types of e-learning that we can learn from this, but I will not deal too much, just to show you that there's what we call as a computer managed learning, when it's about two-way communication between the student and the computer. But once the student utilizes multimedia or there's active participation, it becomes a computer assisted instruction. And there's also what we call as synchronous and asynchronous online learning. Now, what we're doing now here at the ELSA Virtual Congress, those who are on connected now, those online, who has logged in, you are actually now doing asynchronous online learning. However, when this is recorded and then already available to a website, it becomes a webinar or an on-demand platform. It becomes an asynchronous learning. So our doctors who are not able to attend now still be able to see the recorded platform, the recorded sessions here in ELSA. We also have the fixed e-learning and the adaptive e-learning. Okay, so I'll talk about the adaptive e-learning. Is that this is the platform is redesigning learning materials as the individual learners are. So in surgical education, we do a lot of adaptive e-learning. Why? Because there's a lot of trainees have different skill set, have different cognitive capability. So it means that there are some doctors or some trainees that are very fast learners. I met a lot of them. One is Allen. You just seen one. He's one of the very fast learners. So he's a very adaptive learner. Then the other one is linear e-learning and interactive online learning. The video conferencing platform that we do, like this one, like the Zoom, is an interactive online learning because it actually enables us to have two-way communication on real time. Then we have the individual online learning and the collaborative online learning. There's a lot of study between comparing both of them, but what shows now, especially now that we are all using online technology, the collaborative online learning actually has a more impact on the students because it actually builds the skills, teamwork abilities, the interaction, and they learn from each other. Of course, I think it was already mentioned the benefits of an online learning as it is faster, wider scale. And what we usually do use now is the blended learning. And now, if you look at our platform that we're using, is a video conference platform, it actually facilitates a borderless level of learning. It's real time, promotes collaboration, and it actually provides an opportunity to track and record the progress of our online learners. So we go to the insight with regards to the online learners. So when we as teachers or as mentors, when we teach, we are focused more on the objective, the platform, the way how to get to deliver, but we also need to know how we deliver, on how effectively we deliver our programs. And one insight coming from Professor Max Aby, that because he believes that online learning will revolutionize surgical education, he mentioned that young doctors now who come out of medical school, they want to learn, and they want to have, but they want to learn on their own time. And that's why we as educators has to change, because society is changing. We have to adapt to what is happening in the society. And then when the pandemic came in, pandemic has really become an avenue, no, to forge neoliberal values in education. According to them, based on the Rappler that recently published this, that students now, because the schools are starting to come in, students now enroll in online courses, not because they want to learn, but they don't want to be left behind because everyone is using online platform. However, educational institutions are focused on getting the best platform on how they could deliver their resources, but they forget to become human. What does it mean? A student and teacher gap is developing. So we as teachers, we need to understand that we have to make sure and bridge that gap between our students. And why need to learn the insights? See, if you learn the insights, you know the value of learning the insights. If you look at these levels of evaluation, this model by Kirkpatrick has shown that all of us, the reason why we want to learn is because we want to make sure that the patient outcome is good, is better. But what is important is before going or reaching that goal, if you look at the foundation, that you have to have a big foundation, a good foundation, and learning how did the learners really react to the work-based learning experience, and was it enjoyable? So by knowing the insights, it's important that really this is part of a big foundation of your programs that we are actually focusing when we are teaching with our students. So how do you do this? So one tip or one probable directions, but there's a lot, no? This is just one, is to create an educational experience. So a while ago, Professor Chu mentioned about the content, no? That's very important, it's true. And that's where the cognitive presence would come in. Then us as mentors, this is our teaching presence. We want to make sure that our students are engaged with the direction of the goals that we are teaching. However, there's also the social presence, and this is the engagement with the participants. So you have to be aware of all these three phases in order to create and develop as well as achieve that proper educational experience. So let's go to some platforms in surgical education. There are several models, and I mentioned already, there's, as mentioned by our previous speakers, they did show several very good and advanced surgical platform for surgical education. Now, about 279 articles reviewed about model platforms in surgical education, and majority of them really comprise of blended learning, and it identified its principles and effectiveness. So what do you talk about? What do you mean by blended learning? It's a combination between both online as well as an in-person learning, because it is more effective means of instruction. So that was the conclusion of that paper. So I'll give you an example of possible blended learning, and it's being done. And I come across this program by the University of Edinburgh, wherein they really promote group collaboration learning. And the good thing about this is because it actually provides the opportunity to learn from others and to hear how they've applied and what they've learned within their own working environment. This way, you keep on engaging your students as you are actually progressing your program or during the teaching. So I'll give an example, another example of online learning. This is online learning with interactive discussion. So I think we all know use a lot of Zoom, and this platform must use Zoom. And you can see that our residents, our surgical trainees, there's an actual or a very good real-time interaction. You can use the polling, and they've seen this, and you can have good interaction with terms of didactic. But then again, how about the skills? So you can see here that even the skills workshop can be done using the online platform. And here, just show you how they show the trainee and how they teach them. You can actually really monitor their progress. No? You can teach them online, part of telementoring as well, and as well as teleeducation. And it's quite clear. It just depends, and you learn how to do this. No? Like the putting, how do you put your camera angle, what kind of content, and then eventually you debrief after that. You ask the students of what were the learning experience and what were the feedback from them. And that's very important, because as you move along to the next phase of your teaching, you develop your program according to what the needs of the students. So that's what we call adaptive learning as well. Talk about telementoring. It was nicely presented a while ago. And then last July, when we had our Palace Virtual Congress in the Philippines, we invited Professor Wayne Wang as well as Professor Sutep, our president of ELSA, and they talk about reframing the MIS education. And Professor Sutep also clearly showed how the telementoring was done, and he showed one of his slides that it's being already starting to do that. However, what's important here is that he emphasized on the technology and utilization of resources. So for him, you have to make sure that you have the proper resources. So just to finish up, the future direction of online learning is that we as educators in surgery would benefit from being trained in the use of online platforms. However, we need to acquire a wider understanding of the applications and advantage of online platform as well as in the teaching process. So with that, thank you very much for listening, and thank you for your attention. This is what the online learning realities that are ongoing, and I think all of us maybe are also in this kind of situation. Thank you very much.
Thank you, Jeff, for a very engaging lecture. We go to the last lecture for today's session. The title of the lecture will be about training paradigm on single incision surgeries, lessons learned after 1,700 cases. The lecture will be given by a very good friend of ours, a very good friend of mine actually. I really do have the pleasure of introducing Professor Giovanni Dapri. He's a professor of surgery and anatomy in Brussels, Belgium. He's a founder and director of the International School, Reduced Card Laparoscopy. He's an editor. He edited 5 books, published more than 150 scientific papers, presented more than 450 oral presentations. He invented a set actually to operate through single incision laparoscopy and a set through transanal minimal access, minimal invasive surgery. He's an honorary member of our society, Philippine Association of Laparoscopic and Endoscopic Surgeons, and 6 other societies. A very good friend of mine, ladies and gentlemen, please welcome Professor Giovanni Dapri from Brussels, Belgium. Giovanni?
Yes, do you hear me?
Yes, we can hear you.
Yeah, good morning, Alain. I have just a problem to show you. Do you see my slides? No,
Yes, we can see your slide. We can
Yeah?
see
You can see.
You have a full screen?
Yes, we have a full screen now.
Yeah,
Perfect.
so you have a full screen. So perfect. So Alain, thank you very much for your kind invitation. Let me first of all to thanks my friend Professor Mori because he asked me to participate to his meeting in Yokohama and now virtually, and also to my friend David Lomanto and Amir Shabir for the organization of this very nice meeting. So thank you very much. I'm going to speak on the training paradigm on SEALs. And historically, we know that now it was decreased the interest in literature, maybe for the difficulties and also for the not coming, if you want, instruments and the disposable, the availability of other tools in order to do surgery, and the rationale of a single incision remains from a different study, and most of them of randomized controlled trials. The improved cosmesis, because unfortunately we cannot show horizontally the reduced pain, for example, or other important advantages. And here in Belgium, what it happens is that the patient come to consultation requiring a surgery with no scar because they assisted to other friends and they saw the cosmetic outcomes. So the main disadvantages are, first of all, the patient selection. Then there is a longer learning curve, especially for the operative time. There is the difficulties, as I mentioned, for the triangulation of the instruments, for example. And then there is also a cost, because most of the instruments that came onto the market for this type of surgery were disposable. Anyway, here in Brussels, as you probably know, we developed some instruments and also some trackers in order to do SEALs. And we used reusable and curved in order to perform different procedures. And mainly we use free access. One is with just one 10mm tracker for the scope. Another one with 110 and 1.5 flexible for example, other devices. And the final access is a free trackers, 2 flexible and 1 rigid in the middle. Now, for which procedure? We just published our experience in 10 here, and with more than 1,700. And here you see that the experience regards a basic and advanced procedure. So now, to go to the focus of this talk, how we can teach and how a surgeon can be trained with SEALs. First of all, it is very important to achieve an experience in conventional multi-tracker. This is really base. Second, oops. I have a problem. Hello, I have, sorry. Okay, I go back. So second, do you see my slide? Yes?
Yes, we can see.
Okay, sorry, sorry for the technology. Probably is because it's too early here in Europe. Second, to solve, we have to achieve, if you want experience, to solve perioperative complication during conventional, so multi-tracker. For example, bleeding, difficulties in the exposure of the operative field, or perforation of organs, etc. Then it is very important to start with a single, with benign and not acute disease. For example, very clear is to do a cholecystectomy, simple, no after episode of colic of acute cholecystitis. And then it is important also to start with a female. Why? Because usually, especially in US, but also in Europe, male are more fatty than the female, and the umbilicus is not a landmark because it's too down. Then it is important to select a low weight, and especially for rich upper GI, for example, to have a small height because the umbilicus is more closer to the thorax. And the fifth point is to define each single incision step by step and to follow each step systematically. So this means that, for example, if we decide to do a different step and we schedule a different step during cholecystectomy, we have to maintain this step, and we don't have to change because there is a difficulties or because there is other perioperative complication. Then there is the sixth point is to record the single incision every time. And I think it's very important, this is not only in single, but also in multi-trocar, to review each video. So everybody can review the proper video and can see how can improve the proper skills and how can improve the, if you want, the way to go out of the problematics and difficulties perioperative. And 7, to identify, as I just said, the mistakes and to find a solution, maybe with a mentor, maybe with a colleague, to discuss, look at this, I did this mistake, I can improve, etc., etc. And then to replay what we learned at the screen with time, with calm, with discussion with colleague. We have to replay into the OR the day after or after the week when the case is again similar to the first one with the problem. And finally, once we have achieved basic, if you want, lessons for the basic procedure like cholecystectomy, hernia, appendectomy, we can go forward with colic, gastric surgery, or solid organ. And so now I show you, for example, this is one of the first video, and I show you in which way we can do an adrenalectomy in a female, 17 years old, with a low BMI. You see here the access through the umbilicus, the curved instruments, and she was operated of a pheochromocytoma. And this is a huge, if you want, because it's 10 centimeters, sorry, disease. But again, once we have achieved the experience, we can perform this type of surgery and we can go forward. And you see that after we have completely mobilized, we introduce a custom-made plastic bag and we morcellate the disease in the umbilicus, and we replace the splenopancreatic, and this is the final scar. Again, we can do splenectomy. Look at this. This is a huge spleen, but why it's nice to show? Because again, once you achieve experience, and as I just to speak to the young surgeon, you have codified the surgery step by step. You can do the procedure, and you can perform the surgery because you have thought the different steps and you can do it without any difficulties. And if you have difficulties, you can insert, of course, other supplementary trocar, and you can perform your procedure. This is another example. This is a cyst of the segment 7 and of the liver, of course. And again, we can do surgery like we do in multi-trocar because we have to first think about the surgery step by step. We have to codify it, and then we have to do it in a reality. And it is possible once you have achieved a good experience in basic procedure, and then you can do more advanced. And you see here with your access of less than 2 centimeters. And you can do also other procedure like distal pancreatectomy. This is just to show that we can replace different steps in multi-trocar like perioperative ultrasonography, introduction of a stapler, and suture, for example, in a single site. Because again, you achieve your experience, you have seen your video, you have seen your mistakes, you tried the solution, you improve yourself procedure by procedure, and you continue with the successful procedure, also the rare procedure. For example, this is not usual to do a diaphragmatic iatrogenic or congenital hernia out of hiatal hernia. And what we do is like we do by multi-trocar. So first, you see here, we closure the defect by 2 converging non-absorbable suture. And then what we learned, and we repeat in single, is to place a mesh, to tuck the mesh with absorbable device, but also with some different suture into the pericardium, because otherwise we risk a complication of the pericardium like a tamponade, because we tuck into the pericardium, and this is not good. So we can do also other access. For example, this is for colorectal. We do suprapubic. We learned by gynecology. There is less operative pain. There is less ventral hernia. And there is a good cosmesis because the incision remain under the bikini line. So for the lady, for example, as this is the most indication than the male, we can do this procedure, and they can go to the beach with a very nice result because there are no evidence of surgery. So we do the procedure completely intracorporally. We do the anastomosis. We do, for example, linear, but we can do also manual, as I show you. And at the end, when we finish to do the anastomosis, what we do is to remove the specimen through the same access, and we cover the line with the bikini. This is just to show you that we can replay also what we do in multi-trocar, which are the hands-on anastomosis, side to hand, like in America, or hand to side, like we prefer, in order to replace the ileocecal valve after right colectomy. And so what we used to do is to do 2 converging running suture, monolayer. After the posterior one, we open the ileum and the transverse colon, and then we do the anterior suture intracorporally, always with curved instruments, reusable, etc. We can do also left hemicolectomy. For left, we do the suprapubic more on the right side at the level of inguinal hernia, if you want. We place 3 trocars, as I show you, and we do the left like we do in multi-trocar. If it is oncologic case, we start like here with the dissection of the inferior mesenteric vein, and we go forward with the artery, and we respect the principle of oncologic surgery exactly like we do in multi or conventional minimally invasive surgery. And now we can control also perioperative complication. I go fast. This is during a splenectomy. Look at this. We are doing a splenectomy, and during the dissection of the upper pole, we perforate the diaphragmatic muscle, So here you see that we continue the surgery. You see the opening of the chest cavity. There is a pneumothorax. So we finish the procedure. This is the message. And then we close and we treat the diaphragmatic tear by, for example, intracorporeal suture with an extracorporeal knot. And then we finish with the removal of the specimen, etc., etc. This is another complication just to show that we are doing a right colectomy at the level of the dissection of the ileocolic artery. We have a bleeding. Okay, this is normal. We tried to control by coagulation, and this was unsuccessful. So we have more bleeding. Keep calm, like we learn by our mentors. We try to control with the grasper. And so the solution is, like we do in multi-trocar, we have just to replace to first better placement of the grasper and then intracorporeal suture. Of course, we have to learn, but this is just to show, like I show you the different procedures which are advanced, that after appropriate learning curve, we can do. And for the appropriate learning curve, it depends on the organ. You can do with an organ like a cholecystectomy after, I may think, 50, or you can do also after more difficult surgery, close to 80 or 100. And then, this is another example of the left colic artery bleeding. And in order to control it, because we wanted to control a good vascularization of the left colon, we did, like here you see, a suture by polypropylene 50, like we do in multi-trocar, and we preserved the left colic artery. And at the end, look at this, we have a good vascularization, and we continue with the surgery. So there are some messages we learned, for example, the use of percutaneous suture in order to expose the changement of 5 and 10 millimeter in order to introduce other devices like ultrasonic probe or linear stripper, and also to learn in order to do suture. And you can see in the publication, the final scar, the additional trocars, the operative time, considering the difficulties and the step-by-step procedure, the postoperative pain, and finally, the complication due to the access and also the early and late complication. So my conclusion are that the experience in general, laparoscopy, minimal invasive, by conventional access is the base, no doubt. Then we have to start from basic and simple procedure and move forward to more complicated or more advanced procedure. Then, like I try to repeat to you and to teach to the young surgeon, we need to have a codified surgery step by step, and we go forward. And we have also some patient consideration, especially because we need first young patient, especially in the beginning, start with female because the umbilicus is more up than the male. Start with a simple disease, not acute, with a low BMI, no comorbidities to avoid access site complication like in diabetes. And if it is better, to start with no abdominal complication and previous complication like peritonitis because you have adhesion. It is not a contraindication to have an open surgery before, but because you can do, but if you had a difficult open surgery before, this is really not a contraindication, but more difficult. So I finished my presentation with a simple picture of 7 days after a quite obese patient to show you. And I really thank my friend Alain and David and Shabir to have invited me, and finally Professor Toshimori from Tokyo. Thank you very much.
Thank you, Giovanni. Very nice lecture. We still have a few minutes of open forum. Professor Aldohayan, do you want to start the questions for the lecturers?
Yes, I want to ask Dr. Samuel about he's using 3D and animation for training for lab cholecystectomy for the resident. Dr. Samuel?
Yes, yes, I can hear you.
Do you use this animation for training for the young surgeons for basic laparoscopic surgery?
Okay, so when we use the animations, right, for the 3D models in itself, I think it depends on whether the case in itself, whether to what extent they did imaging for the case. For the times where they didn't do imaging, when they didn't do a CT, then you can either use another reference case, or otherwise, you can actually also animate on the internal view, the laparoscopic view as well. So I think this particular part about using the 3D models, I would say is actually it's not a new technology. So we know that actually using CTs to create models, it's been around for a while. But what was actually interesting is that only now in these few recent years where virtual reality has become a little bit more accessible for us is where we truly come to see how we can contextualize the usage of these models and use them to be overlaid in VR. And one of the technical reasons why I find it is quite useful is that in VR, you can actually control the depth perception because you can control the stereopsis in VR. Whereas actually in 2D visualizations, you can overlay something, but you can't see it as if it is really inside the body because you can't control the stereopsis on 2D. But with 3D, you can actually control the depth of different objects, so you can really perceive it to be inside the body. So that's what I find a little bit more useful. I think in the future, definitely, as you mentioned, we're interested to try it in different operations as well, different procedures. But as we go along, we hope we have more chances to try in different operations.
Thank you. Thank you.
Prof. Tudo, do you have any questions for
No, I have. Thank you, Alan. I have no questions.
For all the lecturers, we all know that the pandemic actually changed on the way we train our residents and our fellows right now. But we have to remember, before the pandemic, we have these online classes and everything, and nobody really took seriously on how we would train them. But nowadays, we have a lot of webinars and a lot of online training. If and when the COVID pandemic goes down, do you think we would drastically change on how we would train our fellows and our residents? What's your take on this? Anyone from the panel can answer.
I think I can start, Prof. Alan. Yeah. So I think the future will start to change because technology now is we are exposed. I've been driving this online, and then because I've been involved in the Edinburgh online education for quite a few years after my FRCS. Yeah. But the all over the world, I think there are online platform, educational activities, and then webinars. I usually look for them, and I learn a lot from these online activities because I couldn't travel. I couldn't travel to all the conferences I wanted. But as far as the offline available, I can learn a lot. Like for example, for today, webinars will be recorded, and then I can review again in the future, right? So these are very good resources for the future. I think people will start to appreciate it, and then within this era of the informatics technology and then disruptive technologies, I think people will start to embrace it. Like now, I mean, if the online is available, I would rather have two conferences which I want to attend at the same time, rather I travel and I can only attend once. Yeah, so I think the future we need to, as a the fraternity, we need to look into the technology, disruptive technology seriously, and how can we use the technology to bring the gap. Yeah.
Thank you.
I think I agree with you, Ong. But I think for me the camaraderie is very important, lah. And the social activities are also very important in our conferences. I think Alan will agree with me on that, lah. So this online thing is definitely here to stay. But in what degree it's going to stay after COVID ends is anybody's question. But I don't think it's going to go away. So I think we just have to work around it. And I think we'll end up sending each other virtual beers and virtual drinks and doing that in times to come.
I agree, Kafu. So you look at it, right, in the future, I mean, online will go on to me, and then the physical one, right, we will have a different way of the physical interaction. I mean, like you mean, right, I mean, a virtual, or you may have a small meeting, right, and then we might find it, I mean, it will be become a new normal for everybody. Same for the surgical education. People now look at it, the resident might not want to go for overseas, right, because the resources are available. If we don't embark on it, the other society will keep doing it, right? So if it become a new normal, a new norm for everybody, yeah.
Thank you. Anyway,
President Professor Dabri.
let's give the next session. We would like to conclude this session, this morning session. We would like to thank all the speakers, excellent talks. We'd like to thank everyone, especially Giovanni, for coming in. I know it's very early in Belgium, but
no, thank you to you.
thank you. Grazie mille. Thank you so much. And we thank also Professor Aldohayan and Professor Tunu for joining us today. Thank you.
Thank you. Thank you. See you soon, everybody. Have a nice day.
Everyone.
Have a nice day. Thank you.
Samuel, thank